So we are really honored to have Janet Hager here this morning to talk with us about a very important topic. I want to read the name of her talk because it's longer. I couldn't commit it to memory. It's a Better Exits mission to expand California's End of Life Option Act for medical aid in dying. Janet Hager is a retired physical therapist, as she said earlier to us, and has spent most of her career working with geriatric rehabilitation. And as she says in her bio, her father and husband are veterinarians, and we often are more compassionate in the way that we allow our animals to die than we are with humans. And so she has a great need to really change that, and she is passionately working toward that. And obviously we know this is such an important topic for all of us, and the wisdom that she has to share and the insights is something that we've been waiting for. So Janet, we are incredibly gifted and honored to have you with us to explore this topic and what you're doing in California and what we can do in our own areas to make it possible for people to die with dignity and do this in a compassionate and humane way. And so again, welcome to Mastery Circle. It's an honor to have you here.
Thank you so much, Michelle. I so appreciate the opportunity to come and talk with you all this morning. I truly appreciated Eugenia's spiritual reading and the shares that you all had, and the fact that you all are willing to speak about and talk about death, and in such a positive way too. Many of your experiences have been in a positive way. So our society doesn't necessarily do that. So I really appreciate this group. Before I really get started on talking, I kind of wanted to get a feel from this group as far as how many people know that here in California, we have medical aid in dying available. You can just do it by just a show of hands. And so that's pretty, I would think that the death doula would know that, Diana. So this is pretty typical. Not a lot of you know about medical aid in dying, and that's what we find, is that it's just not something until somebody's experienced a death personally that may have had the opportunity to have medical aid in dying. We just don't know that we have it. So before I can really tell you what a better exit is trying to do by expanding California's law, first we need to understand California's law. So I'm going to spend a great deal of time going over just what that is and what it entails. So our law is called the End of Life Options Act, and it went into effect in June of 2016. So it's been in effect here in California for 7 years. And like all of the medical aid in dying laws that we have available in the United States, it's based after Oregon's law. Oregon is the model, and Oregon's law is called Death with Dignity. Some of you may have heard that. There are organizations called Death with Dignity. And the law actually got passed in 1994, but it met some legal challenges. And so it didn't go into effect until 1997. So depending on what you look at, this is a 26 to a 30-year-old law. And over the course of time, the law hasn't changed very much at all. So, you know, I've told you that not every state has medical aid in dying. So let's look at the states that do have it. And when I do that, I like to think of the map of the United States in my head and sort of start my way as far west as I can go and work my way east. So not in the order that the states put this into law, but in the order that they appear west to east. It's Hawaii, California, Oregon, Washington, Montana, Colorado, New Mexico. Then we skip all the way over. We cross much of the United States, skip all the way over to New Jersey, Vermont, and Maine. And the jurisdiction of Washington, D.C. has medical aid in dying as well. And then if we really look at the countries where medical aid in dying is available, much of Western Europe has it available. They call it different things. Some countries like the Netherlands call it euthanasia. And some countries call it voluntary assisted death, but it's all basically the same thing, although their laws are much more progressive than what we have here in the United States. But so if we look at Western Europe, it's the Netherlands, Belgium, Switzerland, Luxembourg, Austria, Spain, and Germany. And then Australia and New Zealand have medical aid in dying. The only country in all of South America that has medical aid in dying is Colombia. And I find that really surprising because Colombia is a highly Catholic country. And typically we get a lot of opposition from the Catholic community as far as having medical aid in dying available. But they really took the approach that this isn't a moral issue. This is a legal issue. This is a rights issue, and people should have the right to be able to decide when their misery and suffering is so great that they would prefer to die. So they have medical aid in dying, and it's much more progressive than the laws that we have here in the United States. And then the country in the world with the most progressive law is Canada, our neighbor to the north. And Canada's law went into effect the same time California's did, 2016. And over the course of that time, their law has grown every 2 years. They add things, they collect their data, they look and examine. They receive a lot of negative publicity in some of the things that they look at and are exploring, but their law is much more inclusive, much more compassionate, I think. So just as an example, if we look at the population of California, it's about 38 or 39 million people. That's generally the population of Canada. So our populations are very similar. And in 2021, in California, there were about 500 people who utilized medical aid in dying. In Canada, there was about 10,000. So there's a big difference between how many people have the right in Canada to be able to use this. So here in California, how do you qualify? Who qualifies to be eligible to receive medical aid in dying? You have to be an adult, so you have to be 18 years or older. You have to be a resident of California. And residency is not difficult to establish. You can do that by paying rent for, a month or two. You can do it by getting a California driver's license. You can, pay some utilities. So that requirement can be accomplished pretty quickly. Now, both Oregon and Vermont have done away with a residency restriction. So those two states, you do not have to be a resident. So somebody from Idaho can go to Oregon and get medical aid in dying. Somebody from New Hampshire can go to Vermont and get medical aid in dying. But their law also stipulates that you have to stay in that state and take the medication in that state. And I think that's a fallacy, because if I lived in New Hampshire and I traveled 50 miles to Vermont, and then they required me to stay in that state instead of taking the medication home and utilizing it in my own home, in my own bed, don't think I'd be too happy about that. So we'll see how this changes over time, but and I don't know who's going to police that, who's going to know, where that medication was taken. So anyway, those two states have done away with the residency requirement. Then you have to have a terminal illness with less than 6 months expected to live. And that's a big stumbling block. And you'll find out why a Better Exit wants to see that one change. And then you have to be able to communicate your own healthcare decisions. You have to be considered of sound mind, to have mental capacity to make the decision. And this medication has to be self-administered. So initially that was thought that it had to be swallowed. But there are a lot of people who at the end of their life, when they're within 6 months of dying, have lost the function of swallowing. So the American Medical Association and the California Medical Association have defined ingestion as anything that's introduced someplace within the gastrointestinal tract. So for those who aren't swallowing and have a feeding tube in place, the medication can be introduced through that feeding tube. For others who don't have a feeding tube, it can be introduced through a rectal tube. So the person has to have an enema, have a rectal tube placed, and then the medication can be introduced through that. but it still has to be self-administered. So it still has to be the person pushing the plunger. And I hear some groans over that, which
Let me stop you for just one moment. Laura, you're a phone, you are not on mute.
What?
Laura,
Oh, okay. Oh, how do I put it on mute?
yeah, Laura,
thank you.
Cancel?
I'm so sorry. Janet, we're just,
And Michael.
Michael needs to be on mute. Okay, thank you. Good. Laura's, when Michael's will go on mute. And I think that's everyone. I'm so sorry, but we just don't want to miss any of this, Janet.
No,
Have a
that's
disruption.
fine.
All right, go ahead, please.
That's fine. So again, yes, it has to be self-administered. So the person that may be be introducing the medication through a tube is going to have to push the plunger on the syringe. So those are the qualifications. Okay. Now, for people who meet those qualifications, how do they actually access medical aid in dying? How do they get the prescription? Well, you have to have a prescribing physician. And in California, and most states, it can be really difficult to find a prescribing physician because they're pretty secretive. They are not publishing this. It's not out in the open. They're becoming less secretive. This is becoming seen as, I think it will become a true specialty. There will be physicians who are maybe hospice, palliative care, and medical aid in dying physicians. So, but for right now, it can be kind of difficult to find a physician. There are 2 organizations that will help match somebody that's considering medical aid in dying with a prescribing physician. One of those is End of Life Choices California, and they'll work with somebody. They also will provide a physical presence when somebody ingests the medication. And then the American Clinicians Academy on Medical Aid in Dying. That's a real mouthful of words, but they are the newest physician-driven group that's trying to bring together physicians, nurses, hospices, pharmacists, advocates to work on medical aid in dying. So they have 100% been able to find somebody who's interested in having medical aid in dying, a prescribing physician. So once you've found the prescribing physician, the patient has to meet with that prescribing physician and actually verbally tell them that they want medical aid in dying. They don't have to use those words, but they have to say that my life is miserable, I'm suffering greatly, I just really want to die. And so those 2 verbal requests need to be 48 hours apart. It used to be they had to be 15 days apart. So there was recently an expansion to our End of Life Options Act. It was Senate Bill 380. And what it did is it shortened the time frame between those 2 verbal requests, because Kaiser Permanente of Southern California did a study and found that there was a large percentage of people that were dying between their first request until that second request 15 days later. So California has shortened the period up to 48 hours. And then you also need a second physician. And that physician is going to just say that you meet the requirements. You're an adult, you have sound mind, you are expected to die within 6 months. You can self-administer this, you're a resident of California. So that's the really only role that they play. And then in addition to the 2 verbal requests, there is a written request that the patient has to sign. And it's really just a California form that stipulates that this person is requesting medical aid in dying, and the patient has to sign it along with the prescribing physician. And you need to have 2 witnesses. Only one of those witnesses can be a loved one or somebody that may, end up with your estate. And only one can be within a health facility that you may be attending. So if you're in a hospice service, you can only have 1 hospice employee who may sign that as a witness. So you could have a family member and a hospice employee. So that's how you access medical aid in dying. 2 verbal requests 48 hours apart, a written request, and a second physician who will say that you've met the requirements. So what exactly is this medical aid in dying? It's not just a single pill that somebody swallows. So it is a ever-changing and improving concoction of right now 5 different medications. And each medication is in a pretty large dose, so that combined they are lethal. One of the medications is phenobarbital, which is a great sedative. And it's the beauty of it is it's absorbed within the stomach, and the rest of the drugs are absorbed within the intestines. So for somebody who has a lot of nausea, who has a stomach that's really not, it's kind of paralyzed, it's not moving things into the intestines very well, they will absorb the phenobarbital. It gets absorbed in the stomach, but the rest of the medications don't get absorbed until they pass into the intestines. And so there can be a long break between them being sedated unconscious until they actually die. So phenobarbital is one of the medications, and then diazepam, which is another sedative, digoxin, which is a cardiac medication, morphine, which is an opioid. And then they've just recently added a medication called amitriptyline, and amitriptyline is actually an antidepressive medication, but it has a side effect that it increases the heart rate. And what they found is that as somebody's oxygen level drops, as they become more and more sedate from the other medications, that instead of dropping the heart rate, which they thought they wanted to do initially, that if you increase the heart rate while it's getting less oxygen, it will actually bring death about quicker. So that's been a really good addition, because it has allowed people's deaths to occur more in a 2-hour range than an 8-hour range. So those are the medications. They are put into a fluid. It needs to be, they used to think we needed to use about 5 to 6 ounces of fluid, which is a lot of fluid. They've gotten it down to about 2 to 4 ounces. So it's much less for somebody to have to try to drink or to try to get in through a tube. The liquid, because it has gone into less fluid, it's a little bit thick. It's kind of like a milkshake, I guess, or some thick fluid, tomato juice, something like that. And it will cause unconsciousness in about 5 to 10 minutes. And on average, death occurs in about 30 minutes to 2 hours. But it can take much longer. And the people that it can take much longer are those people that have really bad GI absorption. So a lot of our patients who have some kind of GI cancer. And you look at them and you think they're the people that are going to die quickly because they're cachectic from their cancer. They've been doing poorly, and you just don't think it will take very much. And they can be the patients that take the longest amount of time. So that's the information on actually what the medication is. One of the things that our law did when it first went into effect, or one of the clauses that the legislature decided it needed to place on this law, was to put a sunset clause on the law, so that the law would finish at a certain point in time. It would be done. So they put this sunset clause on, and initially it was for 2026. The law went into effect in 2016. So they said, let's have it be in effect for 10 years. And during that time, we will collect data and make sure that this law is not being abused in any way. So that Senate Bill 380 that took the 15-day wait period down to 48 hours between the 2 verbal requests actually lengthened the sunset clause. So now the law is allowed to go until 2031. So they lengthened it by another 5 years. And again, they're just trying to collect data. So they put that on the Department of Public Health, and every year they're required to put out a report on who has utilized medical aid in dying the previous year. So far, the only information that's available on the internet is for the year 2021. So as we look at 2021, in that year, there were 772 prescriptions written. Again, we are a state of 38 to 39 million people. There are very few people that know about this, This is not something that the medical profession tends to tell people is available. You know, nowhere when you go in with a cancer diagnosis and you have a short period of time to live, usually your oncologist is not going to say, well, you know, there's chemotherapy, there's radiation, there's some surgery we could try, and there's medical aid in dying. They just don't say that. So, you know, this is not something that a lot of people know is available. And it's pretty hard. You have to jump through a lot of hoops in order to get this medication for yourself. So, so there weren't very many prescriptions written. And of those 772 prescriptions that were written, 486 people actually ingested the medication. And that's pretty typical as we look over the history of the medication. It's about 500 people a year in California that actually utilize medical aid in dying. And if you're wondering why there's a discrepancy between the number of prescriptions written and the actual number of people who ingest this medication, it's because for some people, they get it as an insurance policy. They get it so that they have control over a peaceful death should their symptoms not be well controlled at the end of their life. So my husband in 2013 was diagnosed with pancreatic cancer. And David was one of the lucky people who lived for 6 years with pancreatic cancer. But the last year of his life was pretty difficult. And David was a savvy medical consumer. He was both a veterinary radiologist and an MD radiologist, and he knew what pancreatic cancer looked like. And he was a person who was always in control. And so he knew he wanted some control over the end of his life. So in the last few months of his life, he pursued and went through everything to get the medication. And we had it here. And he was definitely not doing particularly well. And I said to him, you know, baby, you do not have to endure this. You have another option. And he'd say, I know that. But he says, I've rallied before and I may rally again and have some good days. So he just wasn't quite ready. But it was very reassuring to him to know that he had that medication, to know that he could have a peaceful death if that's what he chose. So one night, David went to sleep and he did not wake up the next morning. He was unconscious. He was in a coma. And for the next 6 days, he lingered in that coma. And that would have made him very upset. He would have loved to have had an advance directive that would have been able to say, if I become comatose, then I would like for my healthcare surrogate, who was me, to be able to go ahead and say, let's give him medical aid and dying, you know, end his life. And he would have hated what it did to me for his final 6 days. So, but that wasn't an option. And my promise to him as I was filling him full of more morphine and Ativan on an hourly basis was that I would advocate to expand our law. So that's where all of this comes from. This is where all of my passion and energy comes from, is from that promise. So as we look at the nearly 500 people in 2021 that utilized medical aid in dying, about 88% were 60 years or older. That makes sense. About 66% had cancer. Again, that makes sense. Cancer is often a terminal illness. You can typically tell when somebody may have 6 months or less to live, although physicians will admittedly tell you that they're very bad at prognosticating life expectancy. About 13% had some type of neurologic disease. The majority have ALS, amyotrophic lateral sclerosis, or Lou Gehrig's disease. That's the number one neurologic disease that ends up using this medication. About 92% were on hospice care. Again, it makes sense because hospice has that 6-month criteria. It's very easy for people that are in hospice services that have mental capacity to be able to get the medication and utilize it. These other two statistics I like to throw in because our opponents to medical aid in dying like to say that, you know, this is something that's going to be utilized for people that are marginalized in society, people that are poor, people that are uneducated, people that don't have health insurance. But the data just doesn't show that. So as we look at the data, about 77% of people that utilize medical aid in dying have some level of college education. These are people who are educated. It's not easy to access. You have to be savvy and know about these things. So they tend to be educated people. About 99% had health insurance. So these aren't people that are poor that don't have any kind of health insurance or means to be able to get this medication. Just some other interesting facts that I find with medical aid in dying is that utilizing medical aid in dying does not negate somebody's life insurance benefits. So this isn't not considered suicide. And on the death certificate, the underlying health disease is the reason, that's the cause of death. And nowhere on that form does it say that somebody utilized medical aid in dying. So had my husband actually utilized it, his cause of death would have been pancreatic cancer, not medical aid in dying. And then the cost of the medication is somewhere between $700 to $800, and it's typically not paid for by any health insurance. Because Medicare and the VA system are both federally funded insurance programs, and this is a state law, they will not pay for the medical aid in dying medication. Kaiser does pay for medical aid in dying medication. Also, I understand that Medi-Cal will pay for it, particularly if somebody is on hospice services, they will pay for medical aid in dying medications. So, so that is sort of a big overview of what medical aid in dying in California entails. And you can translate that to the other states that have medical aid in dying because their laws are very similar. So what is a better exit trying to do? Why do we feel passionate that we need to expand the law? And in order to kind of understand that, we need to go back to who qualifies. So if you need to have less than 6 months to live in order to get the medication, and you have dementia as your sole diagnosis, you will never get medical aid in dying, because by the time you're within 6 months of dying, you are not going to be of sound mind. And many people who have a dementia have witnessed a loved one that had dementia. There tends to be a genetic component to this. So they've seen, or they know somebody, they've seen people go down this road and decide that they don't want to go down that road. So without medical aid in dying available to them, those who have the means may go to Switzerland and achieve a peaceful death there. Switzerland is the only country in the whole world where you don't have to be a resident to utilize what they call voluntary assisted dying. And so some people with dementias are the president of A Better Exit and the vice president of A Better Exit. Both took loved ones. They both accompanied loved ones to Switzerland to get a peaceful death. So they feel very strongly that we need to change this here in the United States, and particularly here in California. And then the other reason is for those people who have some type of neurodegenerative disease. So our people with ALS, some people with multiple sclerosis, Parkinson's disease, supranuclear palsies, Huntington's chorea. Some of those people, by the time they get within 6 months of death, are no longer able to swallow, or are no longer able to push a plunger to introduce the medication. So this is a 60 cc plunger syringe, and 60 cc's is 2 ounces. So if somebody has to have 2 to 4 ounces of this medication that they have to push through a tube, they have to push this plunger. They definitely have to push it down once, and they would have to push it down potentially twice. And for somebody that has ALS, that's not something that they're probably going to be able to do. It's unlawful for any physician or somebody that's at bedside to help push that plunger, even if the patient initiates it. So if they initiate it and get it this far and they can't push it anymore. So we want there to be an injectable option. Almost every other country that offers medical aid in dying has an injectable option, an IV. It's much faster, it's reliable. There's not all this guessing. Is it going to take somebody 30 minutes to die? Is it going to take them 8 hours to die? And you know, it could still be self-administered. We have opponents that say you will never find physicians that are going to give somebody a lethal injection, which is not true, because again, every other country that's providing medical aid in dying and doing it by IV, those physicians are doing that. And as I've talked to the physicians who are part of the American Clinicians Academy on Medical Aid in Dying, they'd like to see an injectable option. But it could still be self-administered. You know, for those opponents that say, well, you know, you won't find physicians aren't going to do that. They shouldn't do that. Their Hippocratic oath keeps them from doing harm. It could still be self-administered by the push of a button, the turn of a knob, something very simple. There's even ways now that technology is finding with eye control that somebody could, with a computer keyboard, you know, spell something out, start, go, something that would start the IV flow. So we just feel like that's much more compassionate than requiring somebody to drink a horrible tasting fluid or to have an enema and have a rectal tube placed as their final memory in life. So so we'd like to see the injectable option. Then the third thing we're asking for is for those people who are in the early to mid stages dementia, and that's their only diagnosis. They don't have another diagnosis that's going to, you know, cause their death within 6 months, that they could fall back on that they be allowed to be assessed by 2 physicians. And if those 2 physicians agree that this person has mental capacity to know what it is they're asking for, and that they know the consequences. Yes, if I take this medication, I'm going to die, that they should be allowed to have medical aid in dying. So those are the 3 specific things that we'd like to see expanded in this law. The way that we're doing this, or the way that we're trying to achieve this, is really 2-pronged. Number 1 is something that I'm doing today. We're trying to educate both individuals and organizations about what medical aid in dying in California entails, where we feel the shortcomings are, why we feel the law is so restrictive, particularly when compared with other countries. And so we're just trying that, and then to get people to support what we're doing by going to our website, which I will put up here at the end. I hope I can share that. And joining our cause, you know, to join us in support of what we're trying to achieve. And when you do that, we really ask for a name. We ask for a physical address. The reason we ask for a physical address is because we then know who your assembly member is and who your senator is. So as we go to those offices, we can say, hey, we've got 1,000 constituents in your district that are in support of what it is we're trying to do. That speaks to them. So that's our first prong. And then our second prong is actually building relationships with the legislators. We're particularly working with the legislators, the senators and the assembly members who are in the health committees in both of their chambers. And also then the first term senators and first term assembly members who may not be familiar with our law and why we feel it has such shortcomings, and just to garner support from them so that when they see this, you know, come as a bill on the floor, that they would vote in favor of it. And also in our dealings with legislators, just trying to find somebody that wants to author that our proposal as a bill, or co-author it as a bill, and that will kind of champion what we're trying to do. So with that, if I could see about sharing my screen. And there's my screen. There, are you all able to see that?
Yes.
Yes, we can see it.
All right, so there's our website, www.abetterexit.org, and emails can be sent to us at that email address. Our president is Marcia Hoffer. She accompanied her husband to Switzerland. He was a clinical psychologist who was diagnosed with Lewy body dementia, and decided really very early on in his process, I'm not going down this road. So he went to Switzerland and achieved a peaceful death there. Christy Golem, our vice president, accompanied her mother, who had Alzheimer's. Her mother was more in the mid stages of the disease, was actually living in a memory unit, but qualified in Switzerland. And so went there. She was adamant. Her husband actually had taken his own life. He had prostate cancer, and at the end overdosed. Medical aid and dying wasn't available yet in California, so he took a whole bunch of his medications together, and it worked. And our secretary is Barry Price, and I'm the treasurer of A Better Exit. So so that is my presentation. And I am happy to answer questions or just discuss this topic further with all of you. And I appreciate your attentiveness on a subject that's can be kind of difficult to discuss. So
thank you so much. That was just superb presentation. I thought I knew more than I did. So I really learned a lot. Thank you so much.
you're welcome, Mary Grace. Thank you for having me. Thank you for arranging this.
Absolutely.
And thank you to Eugenia, because you, I think, were because I already spoke with Eugenia's UU group in Antelope Valley. So
That's lovely. Thomas, your hand was up.
Yes, I do have a question or two. Thank you, Janet, for the presentation. It's been timely for a long, long time, and which sort of shades my questions. When my father was under hospice care in 1992, the only option we had was to withhold medications that were keeping him alive. And he was not able to speak. And I saw what was going on. So I used the blink once, yes, blink twice, no way of communicating with him, and asked him a series of questions so he could be in charge of his own decisions about it. And he wanted to have his medications stopped so that he could die. And so that's what we did. And he directed it. And it was great because it healed an estranged relationship in the last couple of weeks of his life, as somebody else mentioned earlier. So one of the questions is, this is only about active, and it's only about alimentary canal, right? Because parenteral drugs are defined as everything outside the alimentary canal. And so none of this conversation is about parenteral drugs. Is that right?
correct. Yeah, parental is really through an IV. I mean, it's usually a PICC line that's placed that that you can get nutrition through. So yes, this has to be introduced through the GI tract someplace. So it has to be either swallowed, it has to be introduced through a feeding tube that's already placed in the stomach, or a nasogastric tube could be placed, or the rectal administration, or they're even doing like ostomy sites. They can introduce it through an ostomy.
Okay.
As long as it's accessible and doesn't have a lot of maybe cancerous growth that would keep the medication from being introduced.
So it's all still focused on the alimentary canal.
Correct.
Basically. Okay. And the other is there's nothing in here about withholding medication. So it's very specifically about the option of an active induced
Correct.
transition.
Correct. So interestingly enough, our Supreme Court said that there's not a constitutional right to death, to decide to take your own life. It's not constitutional, but it is constitutional to withdraw anything. You can refuse anything. So a lot of people in that who do have dementia may voluntarily stop eating and drinking. That can take 10 days to 2 weeks for somebody to die. And to me, that's cruel because it's a death by dehydration. And the end result is the same. This person at the end of that time is dead. So what does it matter whether they voluntarily stop eating or drinking or they receive medical aid and dying? I think it's cruel.
I understand. Thank you very much.
Carol, you have your hand up.
Yes, Janet, thank you so much for your presentation. I watched my mother deal with 12 years of Alzheimer's, and she was in hospice for the last 2.5 years of her life. And this is very close to my heart, and I appreciate the work that you're doing. I missed the third of the 3 changes in law that a Better Exit is asking for. Would you mind going over those changes again, please?
Not at all. So we want to see them not have a time limit, no 6 months. Get rid of the 6-month criteria. Base this on somebody suffering. Base this on the trajectory of the disease. You know, we should not be looking at a timeline. To me, it's not okay to say, well, you know, you're probably going to die in 6 months, so we'll let you die a little early. I think all of us need to decide when it is that we've endured enough. And so the other is to have an injectable option instead of only having an option that's through ingestion. And then the last one is to allow people that are in the early to mid stages of dementia to be assessed by 2 physicians. And if those 2 physicians feel that they have mental capacity, to be allowed to have medical aid in dying as an option for a peaceful death.
So it sounds like I'm really focusing on the dementia aspect here. It sounds like one must do this quite early in the process of dying via, I don't know, Alzheimer's or whatever other dementia is they're dealing with. I'm just wondering how practical that is.
Well, as I said, there are a lot of people that are in those early to mid stages of dementia that don't want to go any further down that road and will choose to leave time on the table. Now, what I'd really love to see is an advance directive where somebody could say, when I no longer recognize my loved ones, then I would like to have medical aid in dying. I would have loved it for my own husband, you know, that if I become comatose, and I'm not going to recover from that coma, then go ahead and give me medical aid in dying. But we felt like an advance directive was much too aggressive for our California legislators to agree to. So we tried to pick things that we felt were very reasonable, that we felt we could get support based on other countries that are already doing this, and just based on feedback from some legislators that we talked to, physicians that we spoke with, lawyers that we talked to. So we tried to pick things that, you know, is this going to be the whole thing? If we were to get a law that gave us what we want right now, we would probably come back again and say, now we want more. Yes, because we still would, that advanced directive, like you said, when you get to a certain point, you know, somebody could say with dementia, when I'm no longer able to feed myself or walk, you know, then that's the point. Everybody would have their line drawn in the sand that I don't want to go past that point.
Thank
But
you.
that's not
And
what we're
we have-
asking for now.
Thank you.
We have 2 more hands up, Afton and Rena, and I don't know which of you had your hand up first. So Afton, could you go, and then Rena, please?
Yeah, I wanted to just share a nightmare story. My best friend wanted to help her husband, who had been a priest, a Catholic priest until he married her. She wanted to assist him in dying. He wanted it. They had to go to Mexico. They didn't want to tell anyone because they didn't want anyone else to be liable for assisting someone in dying. They spent 3 days in the process. They weren't able to do it right away in what they studied and researched. It was a horrible nightmare for her. And then she came back here and lived in paranoia all the time that she was going to be arrested and accused of murder. So that's how bad it can get. I just wanted to share that. It was a total nightmare.
Thank you for sharing. Yeah, most of the people that really are our biggest supporters are people who have some sort of have experienced some sort of awful situation with trying to help somebody else at the end of their life have a peaceful death. So,
Rena, you're next. Thank you.
Yes, thank you so much, Janet, for educating us on that and on options and having choices. I was aware that there's another group that is supporting people to to go through this end of life by laughing gas. And what do you know about that and that method?
Right, right. So that organization is called Final Exit Network. And Final Exit Network uses an inert gas. So they used to use helium, and then they put oxygen and helium. So they're using nitrogen, and they will provide someone the information on how they can use this to achieve a peaceful, quick death. It's very effective. You make a plastic hood that you put over your head. You turn on the flow of the nitrogen, and people are typically unconscious within 30 seconds to a minute and dead within 6 minutes to 15 minutes. So yeah, that's Final Exit Network. You still have to have some medical criteria to qualify to have them give you instruction, but it's much more lenient and much more inclusive than medical aid and dying.
Yes.
Thank you, Rena.
Yeah.
Is there anyone else with a question? Don't see. Well, Janet, this has been.
Stephanie have a question again, or is her hand still just up?
No, I have a question again.
Oh, okay.
I've sat with 3 dogs, putting them to sleep, and it's much faster. It's like that. Why don't they have the same process? It's like 2 or 3 minutes before they go unconscious with the first one, and less than 20 minutes before they're actually gone. Why isn't it the same way?
Well, you are preaching to the choir, because my husband and my father were veterinarians, and I grew up, with euthanasia as a compassionate, humane thing to do. And it is one of my biggest peeves, is that we are much more compassionate, and veterinary medicine does end of life much better than human medicine. And David was definitely in favor of euthanasia. So I don't know why. It's because animals are animals and people are people, and some people see that as a big difference.
It's the same drugs, but just a different way of.
Well, yeah, in veterinary medicine, they use pentobarbital as an IV injection, or Nembutal. And Nembutal is what people were going to Mexico to get. But it's not really available for human.
Oh.
Here in the United States. So
in veterinary medicine is you used to have to drag your dog in, and now they have vets. That's all they do.
Yeah, believe me, I was this close to calling on David's veterinary friends and saying, you guys, please somebody come and stop this, and I couldn't do that. I would not put somebody in that position, but it was this is why I'm so passionate about this. To me, it was his 6 final days of life, if you call that life, were served no purpose. It was not what he wanted, and it was not what he would have wanted for me. So yeah, I agree. Veterinary medicine does this much better.
Lavita will have one more comment.
Yes, thank you, Janet, so much. I have worked with and for hospice, and have put down animals and buried parents and family members. How did this get so politicized? And why, it's like initially hospice was sufficient in covering, maybe not assisted, but covering pain and suffering of the family. They had therapists and chaplains and all kinds of things. And now, if I heard you correctly, and I just in December had to put my cat down, and they took 5 medications this time. I've had one before where it was one shot. Excuse me, I'm really emotional about this. I don't understand why it's just getting more complicated and political. instead of compassionate and medical and humane, honestly.
I wish I had an answer for that question because we could probably bring this to a much faster conclusion, but I don't. I don't know why it's so politicized. I don't know. You know, again, we as a society in the United States handle death very poorly. I know that from my personal experience with my husband. Even after David died, I would be walking down the street and I would have neighbors who would literally cross the street to go to the other sidewalk, so they didn't have to confront me. They didn't have to figure out what to say to me. We just do not talk about death in the United States. So it's a stigmatized subject. And people see this as suicide. And, you know, we've had to change the words from, you know, it used to be physician assisted suicide. We've had to change a lot just to try to have it be less objectionable to some people.
I mean, when you're ill and desperate, to be dragged to another state or another country, that's just insanity for everyone involved.
I agree.
And what about attending to the body after death has occurred in another country? Say, I mean,
Right. So Switzerland's the only country that
locality.
does that. And Switzerland's the only country that does that, and they will send the cremated remains back to the home, back to somebody's home.
Wow.
Janet, this is clearly a conversation that could go on for much longer. I feel guilty having to be timekeeper here, but we do want to thank you so much. The work you're doing is so powerful and necessary. And I know within this group, you have advocates now who are better informed, who know how they can support you in the work that you're doing, because you're doing it not just for people in California, but for all of us, no matter where we live, you're doing that for us. And you know, as someone whose father had Alzheimer's for 8 years and who just helped her 17-year-old cat cross over with music and candles and much love and much kindness. What a difference. What a difference. So again, thank you so much for this incredibly informative presentation that you've given to us. You've gifted us, Janet, and we thank you for that. We
Thank you for the opportunity and for getting a chance to spend some time with all of you.